Then I would like to announce once more Svante Berg. You have your session alone because Dr. Deser is ill, and you have time enough for presenting us your presentation.
If you guys give me the chance to talk about this, I can keep on forever. This is my main interest in life. I think the discussions here has been very interesting because the more you do of this, the more you realize that the problem is not to shift out the disc. The problem is that you have two other parts in the spine in the same segment that you have to take care of and put attention to. And that is actually a very mature view of seeing it, and most of us didn't understand that when we started out. So I'll start from where we started out. The historical perspective in this is actually a Swedish rather odd surgeon that started in the 60s to put metal bulls in between the vertebrae when he felt that he took away a lot during herniation surgery, because at that time you evacuated most of the disc during that surgery, and sometimes he felt it was an empty hole and he decided to fill it with something. That was the first actually intention to create arthroplasty of the disc. Didn't work out too good. One or two cases out of many had some residual mobility, but most of these bullets subsided into the vertebrae and he had a nice fusion. He was even in Canada and did a lot of this surgery too. As I said, rare cases of success, so the method was dropped until in former East Germany at the Charité clinic they started to develop a disc prosthesis. The two first versions behaved more or less like the Fernström bullets. I mean, the end plates were so small, so they subsided and they fused. And then they made the end plates larger, and it started to work. And we got the prosthesis that we all know as the Charité, and before it was dropped dead, it was renamed to In Motion, but that was another part of it. This is the Charité prosthesis. The older ones in this gang have used it, as have I. In the early 90s, Dr. Marnier developed what was later called the Pro Disc. Started out with two fins, but then ended up with one fin on each end plate. And that was about 23 years ago. I came into this business with discs, and the product was acquired by strong companies and thus heavily marketed. It's been walking around through different companies, but it's still on the market, as you know. And Johnson & Johnson bought the Charité from Link, did an FDI trial and very heavy marketing and pricing in the United States. They renamed it and then went out of history. But they forever disturbed the market in the States since they overpriced it so much, so the insurance companies couldn't make a health economic calculation that defended the use of it. So they started to get to be against total disc replacement for quite a while in the States. And then came the new Klondike. Every meeting you were at, you could see new disc prostheses. Most of them were never implanted in humans. Some of them were in small series, and most of them went out of history. And very few of them, since they weren't actually used, they didn't develop the full understanding of what we do when we shift out the disc to something mobile and purely mechanical. But there was one that was never implanted with a little computer in it to tell us at least what it did. But that was never implanted as far as I know. So at this part we started to think of what patients are expected to have a favorable result from total disc replacement in the long run. There were clear advantages from total disc replacement compared to fusions. it's so well studied. I mean, fusions are, we're born with fusions. They started to do it in the 40s, and nobody has questioned fusions as much as total disc replacement has been questioned, since it's a later development. And there's a lot of studies. All studies have shown better results for total disc replacement, or at the least equal results of fusions. There has been no study showing worse result of lumbar disc prosthesis than lumbar fusions. It's undisputable that adjacent segment disease is less common if you maintain mobility. And since I got some extra time here, I'll just tell you about the most recent paper on that. I don't know if you know a guy, a Norwegian surgeon, Christian Hellum. He did a study between cognitive behavioral therapy and physiotherapy intense on one arm, and the other arm they put disc prosthesis in. And that's been published, and it was to the advantage of total disc replacement. But now when the patients passed 8 years, they checked on adjacent segment degeneration and disease, and they found equal frequencies in the group that was never touched by a surgeon and the group that had total disc replacement. So that is, even if it's of course a limited study and this and that, it's an indication that we get at least far less adjacent segment disease when we maintain mobility. We know that this generation comes from your genes, your parents and this and that, and of course we have that tendency in all discs if we have it in one. So some people without being operated would develop another degenerated disc, but if you have a total disc replacement, the risk doesn't seem to increase to have that. And that's important, because that was the reason we started with discs. And of course, the choice of patients, as we've been talking about this morning, is extremely important. And there will always be a need for fusions when treating DDD at some circumstances, sometimes in hybrids together with the disc. But we cannot rule out and say the last fusion on DDD is done. That wouldn't be right. The anterior approach leads to shorter time of surgery, shorter time in hospital, and much shorter sick leave, at least in Sweden. And all the small irregularities that you have in your body, you might have one vertebra that is a little lower at one side and this and that. That has always been compensated by the patient when the discs were healthy, and they can still do that. But when we treat them as we were the god and fix them in a certain way, they cannot compensate for their irregularities anymore. And we have the escape route. If I treated the wrong patient with TDR, I can always fuse later on. I cannot go the other way. If I fuse the wrong patients, I can make them mobile again. I published some results from a randomized control study between posterior fusion and total disc replacement that I did 2003 and 4, I think, and the 10-year results are, we've collected them and written about. One of my doctoral students that is doing it, so it's not published yet, but we can see that the differences actually grow. For the longer you follow these patients, the bigger are the differences. And in that study, we had significant differences between groups concerning back pain, pain improvement, ODI at 1 year, and even larger at 5-year follow-up. Global assessment on low back pain were also to the advantage of total disc replacement at all follow-up occasions, 1, 2, 5 years. I've done this for 23 years, so I've done more than 6,000 prostheses, 7 different brands. I have much better results now than 15 years ago. I'll get back to that. That one part is better selection of patients, better understanding of what I'm actually doing when I'm restoring mobility, and better regime that I was talking about a little earlier. We have had much better implants, both design-wise and size-wise. From the Swedish spine register, we can see that 62% of fusions on DGD are without low back pain or largely better. The corresponding figure for total disc replacement is 87%. So that's quite a difference. And then we added on that, we know that they have much less risk of adjacent segment disease. The materials in the disc has changed and developed. We know that processes with polyethylene has been through some difficulties. We saw it on the Charities, we've seen it with the Pro Disc. Probably it's not because they made fake wear studies, but the processes were idly placed during the wear studies, and in real life they are not always idly placed, and you get a non-centric load of the polyethylene and then it might wear down. At that time all have metal end plates, and some of them were heavily metal, and they disturbed MRI scanning if you wanted to check something post-operatively. I started like 8 years ago to use a fully peak prosthesis from Globus. It's a 3-part device, and what I liked about it was that they did their wear testing in couple motion and with non-ideal positioning of the prosthesis, and I think they were the first one to do that with the mechanical prosthesis. This is what they would look on MRI. As you can see, there's no disturbance whatsoever from the little titanium that you have there, and that's comforting if you need to have a post-operative MRI scanning. So on the route with mechanical processes, we've come as far so that they are MRI compatible. It's no metal on metal, as I told you the problems of earlier this morning. They have translation in AP direction but not sideways. They have developed low enough implants so we don't deliberately shift the segment into hyperlordosis because we have too high implants. And I used it a lot since 2010. But development didn't stop there. As a French very well-known surgeon said, the disc is not a joint, it's a cushion, a mobile cushion. And there was a development of viscoelastic processes that actually started already in the early 2000s by the Acroflex disc by Johnson & Johnson. That was a totally disaster, but they wanted to find something that was viscoelastic. Then we got the M6. It's been heavily used, but it's been some worrying results there. There is a linear loss of height in M6s in the lumbar, telling that the materials wears down, and it's also reported high frequency of spontaneous fusions, probably as an effect of loss of height, and of course some breakages as well. So I gave my interest to a French disc that is, you can see it back there, that is also a viscoelastic one. It's been in the market for 13 years, and it's approximately 4,000 implanted. I've by now done some hundreds. They did extensive wear testing, and they added on translational load since it's a monoblock. It had to be done, and I wouldn't use it if it wouldn't have been done. It's a little more titanium on the end plates than on the orbit, but still you can have very decent MRI scannings if you like to postoperatively. And then when I started it, I had this theoretical problem of that the processes in itself is so stiff. I mean, the loose mechanical ones haven't ever heard of some that where they are not osseointegrated, since there's no loads in the areas between the end plate and the vertebra when they are completely loose. And I thought maybe that would be a problem with the monoblock since it's more stiff. I haven't seen it yet. I follow my patients very thoroughly. I come back to a study that I'm performing, but also before that study started, all the patients comes in for 1 year checkup with flexion extension pictures, and if there would be a non-union between the prosthesis and the vertebral bone, I would see it on the X-rays, and I haven't seen that yet. So that was a worry of mine that hasn't been fulfilled yet, I'm happy to say. This is a prosthesis. They call it something else locally, but we call it SAC outside France. And then we have to take in account the hybrids, because that is our salvation tool. I mean, if you have a patient that has DDD, one segment doesn't fit or two segments doesn't fit for a prosthesis, but one does, we can gain a lot of restored and kept mobility by using total disc replacement at one or two segments while fusing the one that is not sufficient for artificial discs, as we've been told of Rosalie 4 and this and that, and or facet joint arthritis or spondylolysis or spondylolisthesis even. So I do a lot of combination, a lot of hybrids too. You can still have the advantage of mobility where you can have it safely. And since, as you probably understood, I'm very keen on this to avoid facet joint arthritis, and that means that if I have a lordotic spine with facet joint arthritis in L5S1, I can put so much angle in that, so the risk that they would destroy their facet joints at 4-5 will be minimal, because I don't push them into a lot of lordosis there. If I would make a more straight A-lift, I would force them to go more lordotic in the disc prosthesis segment, and probably would end up with facet joint arthritis. This is what I mean, this is not news for you. You've seen hybrids before, but I just felt that I'd show it to you. This is a patient with severe facet joint or severe facet joint arthritis anyhow. So I didn't want to make a mobility restoring thing in L5S1, but I wanted it at the next segment. This is a lady with a lysis of L5S1, but a deteriorated disc at 4-5, and this is a way that I cope with this type of problems. This is a very odd case where I had spondylolisthesis of 3-4 and 4-5, very rare, and just DDD at L5S1, so I did 2 A-lifts and above a disc. I can take my bad pictures before this curtains goes down. You won't see them anyhow. So this is a very odd case, but I like to show odd cases too. I have a doctoral student working in Gothenburg. She's been with me for a year at the clinic in Stockholm and learned to do this work, and she's performing a randomized controlled trial between A-lift and total disc replacement in 1 or 2 segments. It's ethically approved, and it's under registration in clinical trials. And that study is because we have no strong studies. We have the Charité study, where it was an unequal randomization and was designed to show non-inferiority, and they included the trial cases in the statistics, so it's a very weak scientific study. And we need to know how much is the approach and how much is actually the mobility. And that's why she's performing that study. And part of her dissertation will also be on different bone transplants and ALIF that I've used. That is a retrospective one. And she'll also, and that's what she's also reporting the 10-year follow-up on the study that I previously mentioned. That's why it's not published yet, because it's part of her work. So that's an overview over my tour through disc prosthesis from '95 until now.
Thank you. I think you need coffee, but I think this session was very interesting because we had some messages looking at the sagittal balance of the patient, perhaps at the transverse, the rotational problem, looking at the spine, but perhaps it was not discussed at the subpelvic area, the lower limbs, and perhaps also looking at the sitting position. What is the ideal lordosis? We don't know. Do we need more extension ability or not? A lot of new questions. So looking only at the segmental problem perhaps is not sufficient. Okay. You have a short more.
Yeah. Oh, my next is
okay,
before the coffee. Yeah, I continue.
Okay.
If I get the pictures. Yeah. I'm just going to tell you it's much shorter than on another randomized controlled trial that is underway, where I want to compare mechanical to a viscoelastic prosthesis. And I'm not involved with any of the companies, and neither is my family. For fusions, the result depends on whether you get a good bone healing, if you have pseudoarthrosis or not, and then the results depends on adjacent segment disease. For total disc replacement, in my mind, it depends on what happens with the facet joints at the index segments. You got that message since I've been repeating it. So we do everything we can to avoid segmental lordosis postoperatively, preparations on the patient side, on the surgeon side, optimal surgical technique, getting them all the way back there, getting them midline. And on the implant producer side, we have demanded them to make lower implants and to lead the engineering in avoiding these problems. And the producer have to understand the full challenge of it. So this randomized controlled trial is between what I feel is the top of the line mechanical processes now, the one that I previously showed, and top of the line viscoelastic processes, the SAC. And it's a study that is registered in clinical trials. It's ethically approved. We have an even randomization. And except from clinical outcome that we of course will record at 1, 2, and 5 years, we also will check especially on the fate of the facet joints with 3D CT, and I work together with Medical Metrics of the US to study what happens to the facet joints in between these two groups. And the inclusion is more than 1 year of chronic low back pain due to disc degeneration at 1 or 2 segments below L3, where at least 1 segment is suitable for total disc replacement, at least 6 months of active conservative treatment, intense physio, or combined with KBT sometimes. And exclusion is if they have an ASD because they've been through fusion before, or if they are under 160 of length because one of the prostheses has end plates that might be too large then. So we divide them in 3 groups. 1 segment cases between L3 and S1, 2 segment cases between L3 and S1, and 2 segment cases between L3 and S1 with 1 prosthesis and 1 ALIF. We will have, the power estimation gave us 250 patients for this, so that is what we'll do. We have a computerized randomization from the Swedish National Spine Register, Spine head office, so we are not involved at all with the randomization. I've treated so far 85 patients, 140 enrolled. This is, in my mind, a suitable case for one segment TDR. As you can see, I restore lordosis, as we were talking about, since there was no lordosis at all when there was no disc height. But I didn't get it all the way to hyperlordosis. And this is a suitable case for two-segment TDR. You can see the MRIs and you can see the postoperative pictures. This patient has been through my program, as you can see, no hyperlordosis. We take flexion extension x-rays at before surgery and at 1 and 2 and 5 years. This is one of the patients in the study where we did the same flexion extension after 1 year down the line with the sac prosthesis, and it moves nicely, as you can see. And then we include hybrids, whatever reason. This is a spondylolisthesis, grade 1.5, and DDD in 4.5. And they can easily go into this study. Thank you. It was a short one since you want coffee.